Hi, everybody. Thanks for joining the October session for this Journal Club event. We're going to be covering the WMS acute pain management guidelines and 3 associated articles. To get started, we're going to have the WMS guidelines. Mackenzie Raber is going to be presenting those, and Mackenzie, I have allowed share screen, so take it away when you're ready. Oh, just working on audio. Mackenzie, I think you sent me your presentation. I can load it if you need me to.
Okay, sorry. Can you hear me now?
Yes.
My computer connected to my headphones and I didn't realize it. Okay, so let me see, share. I couldn't hear anything. All right. How do I share this again?
Bottom center of the screen, it should be a green icon that says share screen.
Oh, perfect. Okay. Is it doing it? Can you see my screen?
Not yet.
Okay. Yes. Oh dear, it's saying that I have to leave the meeting and then reopen it if I want to share my screen.
You want me to just pull your article? I can pull up your presentation. Just
Well, I edited it a little bit.
If you would like, we can move on to the first article and then you log in and out and we can get back to your guidelines right after that, if that works.
Okay, that's fine.
Okay, whoever feels ready to present an article, I think we've got 3, so whoever wants to go, take it away. Who's ready?
I'd be fine to go.
Yeah, go ahead. Share screen's allowed, so if you've got your stuff ready, go ahead.
All right, let's see if mine will do it. Okay, can we see that? Good, yes, okay, cool. Well, I'm Savannah Chavez. I'm actually a PGY2 EM resident at Summa Health in Akron, Ohio. It's where LeBron was born, if nobody knows where that is, because I didn't. So let's get started on this one. So this is the Battlefield Analgesia in Tactical Combat Casualty Care article. This is actually out of Madigan Army Medical Center. And so the objective of this article was to kind of go through the evidence and line of thinking that contributed to the development of the current battlefield pain control guidelines, which are now formalized as what's called the triple option analgesia approach. And I'll get into that later. This is put together by the Committee on the Tactical Combat Casualty Care, which I'll just refer to as TCCC. So this is 40+ individuals associated with the military who have expertise in battlefield medicine, pre-hospital, trauma, tactical medicine, and also have deployment experience. And so they review all the evidence and kind of makes recommendations and new guidelines based on the changing evidence. And so what this article did was mostly went through the kind of military aspect of things, but then touched a little bit on how this applies to wilderness medicine. Obviously, because wilderness medicine has a lot of roots in military medicine. So the evolution of the guidelines kind of starts with, I think it's like around 1996. Before that, really the only pain option for pain control was intramuscular morphine. This had a lot of drawbacks in the combat setting because for the most part, it had a slow onset of effect. And so what stemmed from that was that providers were tempted to make or to give more doses to achieve a faster effect. And so you ran the risk of actually overdosing a patient by the time the medication reached the systemic circulation. So one of the big shifts in thinking was changing the intramuscular route of administration to IV. And then additionally, they started adding different types of medications. So they started using oral transmucosal fentanyl citrate, which I hadn't heard of. They refer to it as a fentanyl lollipop. It's an oral lozenge. And then they also added ketamine to the list of available options. So the people on the front line were actually really pleased with these. However, they weren't really sure kind of who should get them or when. And so this prompted the committee to develop the triple option analgesia plan, which was basically an algorithm that divided patients into categories based on the severity of their pain and whether or not they had hemodynamic instability. So that was in 2012. And so we'll dive into that in a second. But then 2 years later was when the Wilderness Medical Society released their pain control guidelines, and those were influenced by the thinking that went into this triple option plan. So kind of the principles that the TCCC goes by, they arrange kind of how to deliver medical care into what's called phases of care. So the first one that they teach is called care under fire. And so basically all that means is that there is no medical treatment, there's imminent danger, we need to get everybody to somewhere safe. And so the way that obviously translates to wilderness medicine is if there's an impending avalanche or an active rock fall, you're not focused on giving medical treatment, you're focused on getting to safety. So those concepts are similar. And then the next two phases are tactical field care and tactical evacuation phases. For the sake of this conversation, all that means is that there's a reduced hazard level and you have maybe a little bit more time, a little bit more equipment or people available to help you, but that you're still in the combat setting. So as I mentioned before, they came up with this stratification of pain level and hemodynamics. And so there's mild to moderate pain and then moderate to severe pain, plus or minus impending or present hemodynamic instability or airway compromise. So how they address mild to moderate pain, the goal of this is to basically not cause any altered mental status, because if you're potentially having to participate in your own rescue or evacuation, or even continue your mission, you need to have all of your senses about you. And so what they do is they give this oral combat wound medication pack. And so it consists of an NSAID, Tylenol, and moxifloxacin. So the NSAID that they use is meloxicam, and to talk about mechanism of action for a single second, it affects COX-2, the COX-2 pathway. And so the reason that we go after that one with this particular medication is because we don't want to inhibit platelet function, because particularly in the trauma setting, coagulopathy is a big contributor to patient mortality. So when you think about the kind of injuries being sustained in combat, you want to minimize that effect as much as possible. Of interest, they actually were using rofecoxib before meloxicam. I'd never heard of that medication, but I guess there was some association with cardiovascular incidents and strokes, so they swapped it. So now it's meloxicam. Tylenol, I think we're all pretty familiar with. The only change that got made in the progression was that they increased the dose. So it's now a little over 1 gram of Tylenol. And then moxifloxacin is given because the wounds sustained in combat are presumed to be dirty. And so it's more just to get a kickstart to antibacterial defense while they transport the patients. So moving on to moderate and severe pain without the presence of any instability. The goal here is that with a pain level this high, you have to expect that you're going to alter the sensorium in some way. So this is where that fentanyl lollipop comes in. And this is interesting because it's actually an off-label use of this route of medication. This is typically for people who use opioids chronically, but still experience breakthrough pain. But the military uses it as a, acute pain management. So what's interesting about this is that there's actually two pharmacodynamics that take place. So it's a lozenge that goes in the mouth. And so a quarter of the dose gets absorbed immediately by the mucosa, and then the rest of the medication gets swallowed and goes through first pass metabolism. So by the time it hits the system, it's another quarter of the initial dose that can actually act 2 to 6 hours later. So you get this kind of immediate and long acting effect from a route of medication that doesn't require an IV. So that's useful in this particular category. So then the moderate to severe pain with the presence of hemodynamic instability, they recommend the use of ketamine. So there are lots of benefits to ketamine. It allows you to preserve airway reflexes during its administration. There's multiple ways to give it, and you have dose-dependent effects. So the TCCC recommends aiming for a sub-dissociative dose, so 0.5 mg per kg or less. They don't recommend getting any more because then you start to develop dissociation in addition to pain control. And then what's interesting, I'm still learning about ketamine myself. Ketamine can actually potentiate the opioid effect. So if you're going to use ketamine and opiates concomitantly, you can actually get away with using lower doses of opiates, and you run a lower risk of causing respiratory depression. So that's kind of cool. And then ketamine has been used already in mountain rescue for some time, and I think that's probably related to these reasons. Interestingly, and where there's kind of a difference between military and wilderness is there's an absolute contraindication to giving ketamine, and that's for patients with a history of schizophrenia. From my understanding, if you have schizophrenia, you cannot serve in the military, and so you're more likely to run into a patient with this diagnosis in the wilderness. And so it's just something to be aware of, that you should not give this medication because you can induce psychosis. And then important side effects to ketamine being laryngospasm, the emergence effect. So if you happen to give a dissociative dose, as that starts to wear off, you get neuropsychiatric disturbance. Patients can kind of unpredictably respond to their environment. And then even though this does technically preserve airway reflexes, if you push the medication too quickly, you can induce apnea. So something to be aware of. And then the article did also go over this concept of ketamine increasing intraocular and intracranial pressure. So when you think about the types of injuries that combat personnel sustain, that was a concern. However, recent research has kind of negated that issue. The clinical risk is significantly lower than what it was believed to be, and the benefit of treating pain in those injuries is so much higher that they recommend that those types of injuries aren't a contraindication to using ketamine. And then anything beyond that plan, IV morphine is the go-to. They actually use higher doses than, say, we use in the emergency department. I think it's like 5 milligrams or to 10 IV every 5 to 10 minutes. But again, they definitely emphasize that we don't want to use IM anymore. And so other considerations when comparing military and wilderness medicine settings is there's some legal issues because not all of these medications can be legally carried or transported. That's going to vary from state to state or country to country, particularly if you're flying internationally, things like that. So it's just something to be aware of if you are anticipating having these medications. And then the cost, I think like one of those fentanyl lollipops is like a couple $100. And so, things to consider when who's funding these types of situations. And so overall, the article was basically meant to demonstrate that the wilderness medicine practice guidelines actually mirror some of the principles from the TCCC, even though that triple option plan is not formally adopted by the Wilderness Medicine Society. And then obviously battlefield medicine, once again, translates very well into wilderness because of the context of, it accounts for immediate danger. It accounts for wanting to do things very simply, very quickly, but also very safely. And so just to kind of reiterate this stratification based on patients' pain levels and then whether or not they're hemodynamically unstable. And that's the gist of the article. I don't know if anyone has questions or
Yeah, any questions or comments?
give this back. Oh, how do I? Oh, there we go.
Alex, any input?
No, I thought it was a really good. I thought it was a really interesting article. Again, it doesn't directly relate to wilderness, but I think there's a lot of overlap. And as a PA, I don't have tons of experience with ketamine, so it was really interesting for me to kind of see their guidelines and use for it.
Yeah. I think we'll hear a little bit more about that and broaden our spectrum a little bit more. Thanks, Savannah. I think that was a great presentation for this article. Mackenzie, if your technology situation is ready, can you give us a rundown of the guidelines? And I think we'll expand our knowledge of pain management a bit more here.
For sure. And can you guys see my screen?
Mhm.
Yeah, okay. All right, so we're going to be talking about the WNS guidelines for acute pain management in the wilderness. All right, so acute pain management in the wilderness was recently reported to be that 43% of 1,200 trauma patients transferred via helicopter received inadequate pain management. And so we care about this because inadequate pain management can lead to increased morbidity and mortality rates in the wilderness, especially when you're transferring long distances to care facilities. So why are there inadequate pain management systems in place? Well, the main reason is that there's just inappropriate estimation of pain. So providers can't really tell the pain level of the patient, lack of medication or means of administering medications in the wilderness. Oftentimes it can be out of scope of practice for the providers of different pain medications, fear of any addiction later on, especially referring to opioids, and then concern for clinical deterioration from the side effects of the medications, such as respiratory depression, aspiration, or hemodynamic instability. So in 2013, the Wilderness Medicine Society met up and decided that they need to establish pain management guidelines for injuries occurring in the wilderness. And their goal was to make the evacuations as comfortable as possible for patients. And they did this mainly through a verbal numeric rating scale. So obviously in the wilderness, you don't have a lot of the technologies that you may have in the emergency room. So you're relying a lot on the patient's, how they report their pain is. And then from that, using their pain scale to determine your treatment plan. And then they used, based off of the recommendations they made, they rated them 1A through 2C. And their recommendation chart was based off of the American College of Chest Physicians. So they just used the same chart that they had, 1A being the best and 2C being the worst quality or weakest recommendation. So pain treatment pyramid, it escalates from comfort care all the way up to IV meds. And this is based off of patients, how they report their pain. And then if they're not responding to pain treatments, it would warrant escalating up the pyramid from comfort care to non-opioids, oral opioids, then IM, transdermal, and IV. So what is comfort care? It involves just using empathy, using the patient's name, discussing the pain management with the patient, decreasing their anxiety levels, knowing that they're going to be taken care of and that there is a plan, and then just keeping a team member with them at all time. And you'd be surprised at how much just comfort care can go in terms of, bringing that anxiety level and heart rate down to the more sympathetic nervous system type symptoms, bringing that into check with comfort care. and putting the patient more at ease for transport. And included with comfort care is the price protocol and the meat protocol. So this is just your run of the mill. Price is essentially rice with protection of injury. So the rest, ice, compression, elevation, and that's indicated for muscular injuries and fractures. That's a 1B protocol. And then the meat protocol, movement, exercise, analgesics, and treatments is indicated for ligament and tendon injuries. So just again, first line treatments. So then moving on to the non-opioid analgesics, as we said before, this is first line. There's a preference to combine the NSAIDs plus acetaminophen to gain the best coverage of the pain. And then IV IM ketorolac can be given if oral medication can't be tolerated. And then, as was mentioned in the previous article, the military combat pill pack is often administered, which consists of acetaminophen, NSAIDs, and an antibiotic for any penetrating wound injuries. So then opioids, this is the step-up treatment. So this is very useful if the pain exceeds a required max acetaminophen dosing. And then you want to be cautious if there's any concern for decreased level of consciousness that the opioids could then further exacerbate sedation and decreased respiratory drive. So some key administration routes that are of note for different types of patients in the wilderness. Transmucosal can be really good for burn patients, specifically the oral fentanyl. Intranasal has equal efficacy to IV morphine and can be used for moderate to severe pain. You would want to do IM dosing for patients who are hypothermic, and just because it has a slower onset. And then IV, if you have access to it, super fast, but that's probably not the case in the wilderness, having IV access. And then transdermal, really good for if you have to transport that patient out of the wilderness for miles and miles and days. So really good for extended scenarios. And again, as we mentioned previously, ketamine can be really useful for pain in the wilderness at high doses, is good for reducing fractures, repairing super painful wounds, any needed amputations that might occur in the wilderness setting. And then at low doses, it can treat pain alone or in combination with opioids. You can also use local anesthesia for fractures, soft tissue trauma, removal of foreign bodies, and some basic suturing out in the wilderness. So these are the dosing recommendations for the variety of drugs that can be used in the wilderness. And then any adjunct medications. Some physicians promote carrying benzos to decrease anxiety levels in patients, but the Wilderness Medicine Society has no formal recommendations and hasn't spoken on that at this time. Again, comfort care is probably a better option in decreasing anxiety level in patients. And then lastly, pain management in the wilderness. The goal is to decrease the physical and psychological stress associated with trauma in the wilderness, because aiming to decrease the morbidity and mortality rates of these patients as they're transferred to definitive care. Don't want to see them decrease or de-escalate as they're transferred. And this is my resource. Any questions on the guidelines?
I was just wondering, and this might be like beyond the scope of this conference, in which case that's fine. My understanding of ketamine is only as kind of a dissociative medication. So my understanding has always been that people will still feel the pain, but they won't remember it. Does it actually have a mechanism of analgesic effects?
Based off of the article I read, that's what they implied, but I can't answer that completely for you.
I can comment on it. Oh,
Yeah, I
go
can
ahead.
comment as well. So a lot of the like anesthetics that we use have side effects. So for example, propofol has an antiemetic effect. Ketamine actually has a great analgesic effect. And actually ketamine has different effects depending on the dose that you apply. So generally in the using IV equivalents, 1 to 2 milligrams per kilogram is dissociative. Probably about 0.6-ish is kind of like the recreational dose that folks will use is like for special K. And then the like 0.1 to 0.2 to 0.3 mgs per kilo is actually a non-dissociative or sub-dissociative anesthetic dose. So we've actually used it as like a second to third line analgesic only at about the 0.1 to 0.2 to 0.3 in the emergency department very recently for just an anesthetic as a sub-dissociative or non-dissociative anesthetic, or excuse me, analgesic.
Cool. Thanks so much.
Yeah,
We
you do
like,
get analgesics even at the higher doses. That's like one of the side effects that you get. So for
Mhm.
folks that have a significant like good anesthesiologists that are like interviewing somebody pre like surgery, they'll find out like, do you have a history of post-op nausea? They'll often go for propofol. Do you have a history of like chronic pain? They'll often use some ketamine, and they'll kind of pick the other like side effect sort of profiles of the medication. And ketamine, for example, because of its analgesic effects, will often be associated with like they'll use it for folks that have a history of like difficulty with pain.
got it. Thank you so much. We like just started getting to pain management. I'm only a second year in med school, so we haven't gone over this yet.
No, that's the fun thing about the journal club is it gets you exposure to things that you don't get often until later in training. And I do like the pain party procedure reminder. Thanks, Ben. That's pretty funny. Yeah, I like alliteration too. All right, great job. Thanks for the overview. Any other questions or comments about the pain management guidelines?
We did have a question over here, and it was about the intramuscular use and hypothermia. So we're theorizing that if once you warmed them back up, would they suddenly like get this big pool of drug that was like hanging out, suddenly hit them all at once? I don't know if anyone has any answer to that. But.
Hopefully they would titrate them at a slow enough rate where that would be compensated for.
I have no real world or even theoretical guess at this. I just thought it was an interesting, like, would it be just hanging out until suddenly they warm up and then they suddenly like get drowsy or like, hey, I don't have any pain anymore?
Yeah, even with IV medications, we know that the way your body processes them when you are hypothermic because of your own enzymatic, essentially denaturization. I don't know. It doesn't like process them, and so the pharmacokinetics change when you are cold. You can like imagine too. Your circulation, especially peripheral circulation, goes down with hypothermia. So IM and sub-Q, and actually part of that's the reason that they've now recommended not giving subcutaneous epinephrine in like shock states, but giving straight IM epinephrine in shock states, because as you have decreased perfusion, you will not necessarily absorb the medications. In hypothermia, you get a whole lot of central shunting, which is why you get like cold diuresis, and you would not therefore absorb things that are subcutaneous or IM. In addition to the lack of the like normal pharmacokinetics, when you're really cold, you would expect things to sort of build up. And then as you rewarm somebody, all of a sudden have this sort of flood of all those depot medications. So you would want to be really careful of sub-Q and IM medication.
Just reading through the chat here, there's quite a bit. Ben, are you talking about like giving the benzos after the like the procedural dose ketamine is wearing off? Is that what you're referring to?
Yeah, basically, if you high dose and you're trying to do procedural dosing with ketamine and they start to metabolize off, they could go into that party phase. And so by adding benzos can help alleviate some of that dissociation.
I guess I've never seen it given. I haven't done it. I haven't read much about
Okay.
like positive stuff, but
So actually really interesting if you hit kiddos with kind of high doses for, I used to do a bunch of like peds EM working at CHOP, and if you get kiddos that come out and they have like kind of a bad trip coming out of a dissociative state for doing procedural sedation with ketamine, the best way to kind of smooth that out and make them like not like trip balls is to give them benzos as they're coming down. So especially intranasal ketamine, if you gave it for procedural sedation, if you hit them with some intranasal midaz as they're coming down, it really smooths things out.
I could use some of that too. It smoothed me out.
Great
Yeah,
for pediatric.
I've seen most of my like ketamine quote adverse like psychological effects on the like sedation phase, not the metabolism phase. But I usually like to tell my kids to think of like their favorite TV show or something, have a good dream maybe. And I remember asking a kid, what's your favorite TV show? And they said, Stranger Things. And I was like, no, don't think about that. don't think about that while you're on ketamine. But yeah, I haven't seen much of the emergence, but I've seen more of like the sedation effect. It's kind of fun. Has anybody seen laryngospasm? I've only seen it once. It's terrifying. Okay. If you had a patient and you're on the like the side of the mountain, you give ketamine, they get laryngospasm, what are you going to do? Anybody?
Bag them if you have that, and you can press on Larson's point.
Can you describe that for those who don't know what Larson's point is?
Yeah, it's like the little divot that's behind the mandible and the mastoid process in the ear, and it's real tender.
Just gonna wake them up.
Yeah, you can use it to wake them up too, but you can also try to break the laryngospasm. But I think mostly positive pressure ventilation. And then, yeah, if maybe if you've got a paralytic, but.
That's how I broke through, is I just gave a paralytic, and I was in the ER, I just paralyzed and intubated. But let's say you're not able to bag.
But at the side of the mountain is there.
There was a good article recently about a biker who happened to be an ER doc who rode by somebody happened to have an 11 blade in their bag.
Craig.
Yeah, that's a potential option. It's just keep these potential pitfalls in the back of your mind whenever you do any procedure. Always think of a way to dig yourself out of a hole.
You can, once you get the cry.
I had exactly one, and the nurse like slammed the ketamine in, and they had laryngospasm, and really then you can mostly bag them through it, but otherwise you just paralyze and put them down, put the tube in. And ours was for induction to begin with, so.
Yeah, just put them down with a paralytic if you've got it. You should, if you already got ketamine, I'm assuming you've got more. But yeah, always remember that bad things can happen.
I'd also say be careful with pushing ketamine too quick in general. You want to push it very slowly. If you're pushing quickly, there's a pretty good risk of apnea with the dissociative doses.
I'm pretty sure that's what happened with the laryngospasm case I saw. I think the nurse pretty much slammed it. All right. Any other questions about the pain control guidelines or input? Cool. I think one thing to keep in mind is if you've got a fracture, one of the best things for pain management is just immobilize. You don't have to go straight to meds all the time. You can just do symptomatic treatment of properly addressing the actual problem. I like to keep, if anybody's got them, the little lollies you get in any like dental box, the topical, I believe it's benzocaine for like dental pain. I have it in each of my first aid kits because I don't know how many dental pain patients you've all seen, but it looks pretty miserable. That's just one little thing I like to keep. All right. Otherwise, anybody feel particularly ready to move on to their article presentation? We've got 2 left.
I can go.
Go ahead.
All right. I didn't make a very pretty presentation like everybody else, but I'll have you look at some pictures while I talk about this article. My article was the battlefield acupuncture to treat low back pain in the ED, is in the American Journal of Emergency Medicine. Basically, it was a pilot feasibility study. They were aiming to just evaluate how to improve pain and mobility of patients who came in with low back pain into the ED. But this also stems from the military. The military has been using battlefield acupuncture since, it sounds like about 2001, it was kind of introduced. Obviously, it's a very old medicine, but it just started being introduced into the military in 2001. And I've heard quite a bit about it in the last couple of years, but kind of in only specific settings, but we'll talk about that in the later. This study really emphasized decreasing opiate use, especially in the ED for kind of these acute on chronic musculoskeletal pain complaints. Their population was an urban academic center. Their patients were those who came in with the chief complaint of back pain. It was 18 years old and up. They had some exclusion criteria, which made sense. It was like no significant trauma, no neuro deficits, no pregnant patients. And then their intervention, the control group was the standard of care for low back pain. And then their treatment group was the standard of care plus this battlefield acupuncture. So all patients were being treated with the standard of care according to that physician, which does, change like provider to provider, but everybody was getting the standard of care according to that physician. The primary outcome they measured was the mobility using the get up and go test, and then also the numeric pain scale before and after treatment at 1 hour. And then they had some secondary outcomes that included pain radiation down the leg, range of motion, ED length of stay, med use before and after, and then overall safety. It was a randomized control trial, but the participants and the assessors were not blinded, which I thought was interesting, but makes sense with a procedure like this. It's a little harder to blind. Their sample size was only 30, which is a little disappointing. It was only one center. But overall, I think this is pretty generalizable, especially to wilderness medicine, especially with this, the acupuncture, there's really barely any contraindications. It's pretty easy. If they have an infection on the ear, you can't use it, but otherwise it's pretty applicable to everybody. They probably had some bias just based on the non-blinded patients and assessors. But they did probably have an appropriate exclusion study for the initial feasibility study. I think in the future, it would be great to include the pregnant patients because this could be great for kind of the musculoskeletal pain where you really don't want to give opiates in a pregnant patient. Their results, they, out of all the outcomes they measured, the only one that was statistically significant was the decrease in the numeric pain score. With the battlefield acupuncture, the average rate of pain was 5.2 versus 6.9 without the acupuncture. And this was statistically significant, but none of the other results were, unfortunately. Which I think kind of speaks to the bias in this, if that's the only one that was significant, not the range of motion or the get up and go, anything like that. So probably a little placebo effect here, but that's okay. Their weaknesses, I think there were a couple weaknesses in this, but again, it was a feasibility study. So their sample size was small, it was only 30. They had, I think, initially 200 that were screened, and a lot of them got excluded just because of trauma or neurologic symptoms. I think it's definitely feasible to use battlefield acupuncture in the wilderness. I think it's not necessarily going to be for your fractures or some of your more serious complaints, but I think the risks of using battlefield acupuncture are way outweighed by the benefits of it, even if it is just a placebo effect. So this is the size of the needle, it's tiny, and then this picture on the left is the applicator. You can buy like a pack of 80 of them for anywhere from $50 to like $150. They're made out of like gold or titanium, so I'm kind of questioning if you can reuse them, if you clean them. This training to learn how to apply battlefield acupuncture is really only like 1 to 2 half days. So it's very accessible. You don't need a prescription to get this. They're very lightweight. They don't expire. So I think it makes sense, you know, if you know how to use them. And I think there's, like I said, there's really no contraindications. There's no side effects. It's not going to sedate your patient. Really, there's only benefits that could be brought on by this. I think it's just kind of one of those things in the future. I think if they did more studies where, you know, they did like sham acupuncture and you tested that specifically versus kind of the control group that didn't get any kind of poking of their ear. That would be interesting. But in the wilderness setting, I can't say I'm going to incorporate it in my practice, but I think it's something to consider. And maybe I try it on some friends first. I don't know. But anyways, that's the study. And hopefully there'll be some bigger studies that come out in the future. Oh, I think I actually have more pictures. Hold on. Oh, these are the sites. There's 5 specific for back pain. You're supposed to do them in this order, 1, 2, 3, 4, 5. And that's how they look when they're on. It's almost like jewelry, and they're considered semi-permanent or semi-temporary. I think I've seen both. So they can stay in for a couple days, especially in the backcountry. Like if you know you're predisposed to back pain or all sorts of aches and pains, you could apply these before you leave, and maybe that would offer a little bit of relief. And then I've also seen, I don't know if I'm getting Instagram targeted ads now, but I've seen these acupressure points, and they're similar, you know, kind of the same points of acupuncture, but they're just little stickers that obviously you don't need special training. You can just look those up and apply those yourself even. And then this is kind of almost like the homunculus for the brain. This is like the homunculus for the ear. So this study just did back pain, but as you can see, there's potentially a lot of other spots that could be addressed too. Those are all my imagery sources. All right, that's all I got.
Has anybody had any personal experience receiving acupuncture or seeing patients receive acupuncture?
I received some. It wasn't particularly effective, but it also wasn't covered. So I don't know if it's kind of like you need a certain number of sessions. It wasn't on the ear though. It was like near the actual sites that were involved.
This was my first exposure to specifically ear focused acupuncture placement. It's interesting to see. Alex, you chose the article. What
I did.
drew you to
I was
this?
I was kind of excited to find some of these articles. I have a friend from undergrad. She's a doc in the Navy, and I remember she texted me one day saying she had done like a 1-day seminar on like how to do this and was super pumped about like getting a chance to try it out. I was still in PA school at the time. I had no idea what this was, and so I started looking into it. It was invented by an Air Force doctor. And pretty much all the original studies were all within the military. They were not unbiased, in my opinion, reading some of the early articles on like its effectiveness. So I was trying to find an article that kind of compared it outside of kind of military settings to see what was going on. I think there's some bigger like studies that might be in the works or case reviews or something like that. But yeah, I was really interested in like finding articles on it because I'm interested. A big question I always had was like, I mean, I know people who have ear piercings in most of these places. I'm curious if they have any pain benefits or maybe it's less effective on them because they already have piercings there. But yeah, I was just really interested in the topic, so I wanted to find an article on it.
Yeah, I've heard of actually like specific piercings in the ear to treat migraines, like as prophylaxis for it. But the Air Force actually has its own protocol, I saw too, which is funny because I'm an intern, an EM intern at Brooke Army Medical Center. I'm an Air Force intern, but I mean, obviously I'm a couple of months in and we haven't even talked about acupuncture. What are we doing? Like,
In general, medicine's put a lot of research dollars and time into non-narcotic pain management. So it's kind of interesting to see the different avenues that's going along. Like, I don't know how many of you are at programs that have ultrasound fellowships or ultrasound focused people, but nerve blocks have definitely been on the rise and they're very effective. But I can definitely tell you that other than dental blocks, which take no time at all, they are time intensive and training intensive. So it's kind of interesting to see potential other avenues to treat patients, because it's still quite a problem. Almost every day somebody's in our ER overdosed. Any other questions or comments on acupuncture? Just reading the Mimi, did it feel like it was effective if it was just like the typical generic acupuncture? Okay. But yeah, sorry, Sheilier. Yeah, I'm curious too. I've never been too much of a proponent for like the alternative stuff, because even though I'm a DO and I learned all about OMT for years, I haven't done OMT in years. I'm just somewhat of a skeptic, but yeah, if the studies come out and it's effective and alternative to getting people hooked on drugs, I think it's fantastic. I don't think it works. Interesting. Anyway, so yeah, Mimi's saying that it looks like up to 40% of people at least have little to no effect whatsoever. So that's interesting. I think we have one more final article, unless anybody has any other comments on this one. All right, Ken, take it away.
All right. All right, so my name is Kenny Hunt. I'm a fourth-year student at the University of Queensland, Oshner Clinical School. I'm in New Orleans right now. The article I'm presenting is pre-hospital use of ketamine in Mountain Rescue, a survey of emergency physicians of a single-center alpine helicopter-based emergency service. All right, so a little bit of an introduction. This study published in Wilderness and Environmental Medicine in June of 2020. And I wanted to present this week, I'm really personally interested in pain management. So the study itself, this was a single center prospective online survey. And the center is the Air Glaciers Alpine Helicopter Emergency Medical Service. And this is located in French-speaking part of Switzerland. And the goal is to assess the methods of ketamine use. And this is really the first study to survey emergency physicians on ketamine's use in this particular study. So the research question, the population was all of the HEMS physicians. There's 45 of them. They're contacted by email to complete the survey, and 39 of them ended up completing the survey. 34 were board certified in pre-hospital emergency medicine, and 19 were board certified anesthesiologists. The survey was a 65 question survey. There's no comparison or control group for this. And the outcome was to see, basically just to see what these physicians' clinical practice was in the field. So the primary goal was really to see what are the methods of ketamine use by HEMS physicians. And then the secondary goal was to see HEMS physicians' knowledge of the contraindications and adverse events associated with ketamine. So relevance of this question, there's rescue missions are common. There's 1,700 annually by this group alone, just in Switzerland. So thinking about the rest of Europe, the US, the rest of the world, there are tons of rescue missions all the time. And then same stat as reported earlier, analgesia is inadequate in 43% of traumas transported by helicopter. And then ketamine is recommended by the WMS for acute, moderate to severe pain in the wilderness setting. So particularly useful for procedures that may cause extreme pain, like a fracture reduction, wound repair, or amputation. So for the methods, this survey was emailed to all Air Glaciers physicians. The survey is accessible for 2 months and need to answer all the questions for survey to be validated and included in this data. They collected data on characteristics of these physicians, the methods of ketamine use, knowledge of the contraindications of ketamine use, side effects, encountered after administering ketamine, and then they collected information on a clinical scenario they provided in the survey. And this scenario was regarding the choice and dosage of IV analgesic medication for severe acute pain for a suspected femur fracture in a 70-kilo man in a pre-hospital mountain setting. So before getting the results, just a little bit of a critical appraisal. First off, strengths. It's the first study to look specifically at ketamine in this setting, which I thought was interesting. And then there's a paucity of research in this area overall, so if anything helps. And then they also had an 87% response rate, which is excellent considering a response rate of over 40% is considered adequate. Limitations: single center, small sample size, and then self-reported. And the authors mentioned that they possibly may overestimate their use of ketamine just due to the survey's focus on ketamine, and I agree with that assessment. And then non-validated questions, essentially meaning this is the first time these questions were used, at least presumably. All right, so the primary outcome. All the physicians had used ketamine at some point in their work. The most common indication cited was for acute analgesia during painful procedure. The second most common indication is maintenance of analgesia, and the third most common indication is the opioid sparing effect during acute analgesia. The most common injury sites were the femur, shoulder, and the knee. And then 64% used both fentanyl and ketamine. And the reason given for using this multimodal approach was either to provide deeper analgesia, again, the opioid sparing effect, as well as to calm patients in case of agitation. I thought, interestingly, respondents felt that ketamine had a better safety profile than fentanyl, despite this not being established in the literature. And then 44% co-administered midazolam every single time they also gave ketamine. And this is overall supported by guidelines for reducing emergence reactions with ketamine use. And then 95% used a pulse oximeter to monitor patients after ketamine use. And this was the most common monitor used by far. And the second most common monitoring modality was heart rate by palpation of the pulse. And overall administered less often in children than in adults. And they cited that was due to lack of familiarity with that patient population. And then 33% had given IM ketamine and 18% had given intranasal ketamine. And they stated for IM ketamine that they'd give it for either agitated or aggressive patients, but also if an IV could not be established. And then for intranasal ketamine, they'd either use it in very cold mountain settings or for children. So the secondary outcomes. So as a reminder, they looked at physicians' knowledge of the contraindications and adverse events associated with ketamine use. So 26% reported ketamine not contraindicated in stable schizophrenia, and 23% reported ketamine not contraindicated in children less than 3 months old. Both of these are absolute contraindications. And then 28% reported ketamine absolutely contraindicated in pregnancy, and 15% reported ketamine absolutely contraindicated in severe head trauma. Both of these are not contraindications, although increased intracranial pressure is considered a relative contraindication. So possibly understandable, I think, for the severe head trauma. And then this was the table of their answers. I just thought this was really interesting to see the breakdown. So over here are all the absolute relative contraindications, and then the conditions that are not contraindicated. And then here in bold shows the number of participants who reported a condition as being not contraindicated when it was absolutely contraindicated, and then vice versa. So I just thought these were particularly interesting. And then adverse events, hallucinations were reported to be the most common. Actually, 72% reported hallucinations, and either usually visual or auditory. And then 64% collectively reported that the neuropsychiatric side effects were either generally positive, or always positive. And then to round out the top 5 adverse events reported, again, reported by these physicians, was agitation, hypersalivation, tachycardia, and arterial hypertension. The clinical scenario, 36% chose combination of fentanyl and ketamine, 33% chose ketamine alone, and 31% chose fentanyl alone. And again, this was for a scenario with a suspected femur fracture and a 70-kilo man in a mountain setting. And I thought was interesting, so the recommended dose of fentanyl was 0.1 to 0.5 milligrams per kilogram. And participants used in general 0.2 to 0.7 milligrams per kilogram. So quite a wide range, given the same, everyone looking at the same clinical scenario, and a little bit on the high end as well, especially the 0.7 milligrams per kilogram. So overall utility and summary, I thought this was an interesting look into one HEMS group. I would really like to see this same survey given to multiple HEMS groups and comparing the results, especially a US group, to see if there are any practice differences. And then overall, ketamine seemed to be used in a fashion recommended by the WMS for acute pain, the WMS acute pain management guidelines. So that's for controlling acute, moderate, severe pain, and they gave it a grade 1B, the WMS that is. And then hallucinations common, but often not unpleasant. And although it's impossible to predict which patients may have an unpleasant emergence reaction, thus I think one reason it may not be used as frequently, especially in this setting in a helicopter in a confined environment. And then overall, I thought it was interesting that there's full knowledge of the contraindications. And I'd be curious to see results from other EMS groups. And also, I thought, could be corrected relatively quickly through education. So ketamine meets many of the qualities of an ideal pain medication for wilderness use. And I think it should be remembered as one possible option for pain control in a wilderness setting. And those are my references. Thanks.
All right, thanks. Any questions or comments on another ketamine topic?
The room here, full of many experienced emergency medicine physicians, said they also have pretty positive experience with ketamine, and most of the people who use it or get it are usually also experiencing pretty positive.
Personally and patients.
Personally and patients are experiencing positive effects with it.
Is that in or out of the hospital, CJ?
He's just nodding yes. So
yeah, I've seen pain dose ketamine work fantastically. Procedural dosed ketamine work very well. It's a pretty good drug. When I was in residency, a lot of my attendings were still wary of it, so I didn't see much of its use during, the first 2 years of my training, but the latter 2, I saw more and more, and now in practice, it's pretty effective when indicated. Since this is a journal club, what did you all think of the actual methods and external, internal validity and parameters of the study? The last 2 articles were the first article was more of like a broad picture, but this was an actual article, or a research article. So it was questionnaire based, focused to a single rescue team. So what do you think? External validity is questionable? It was interesting of their lack of knowledge of the contraindications. That was kind of interesting, which is probably more widespread than we'd like to admit to ourselves and our colleagues and things like that. She'll keep that in mind. It's a cool stepping stone. I agree. It'd be kind of cool to see that questionnaire maybe tweaked and then spread more widely throughout the region, and then like internationally would be pretty interesting too. Any other comments on the study itself or pain management in general? All right, cool. Any other questions? Otherwise, I think we can end the recording, and if anybody has any questions on like wilderness medicine and how to get involved, we can talk about that as well. We've had a handful of students email me over the past couple of days saying they wanted to ask me questions about stuff. So we can switch to that now. Yeah, I agree. Cool. All right. Well, thanks everybody. I'm going to end the official recording.